welcome everybody. We appreciate everyone coming out today for the first Crossings webinar of 2023. Happy New Year to everybody. Very quickly, I'm going to let the team introduce themselves, and then we'll get started with the presentation. My name is DeCecco. I am the account executive for Crossings Healthcare. Giovanna, you want to go ahead?
Yeah, hi everyone. My name is Giovanna Ferro. I am an assistant manager at UHS and work very closely on the design, build, and implementation of the Heparin Advisor.
Dr. Reddy?
Hi guys. My name is Marreddy Yeruva. I'm a Chief Information Officer at UHS, a hospitalist by background.
Awesome. So everyone, the venue chat, if you have any questions at any time, you can use that. There's also a button underneath where you can send questions directly to the presenter if you don't want to make it a public question. So feel free at any time during this presentation to send any questions, and then at the end we'll address all the ones that are sitting, okay? But without further ado, welcome to Crossings Heparin Advisor webinar. Just real quick, obviously clicking on this, it's UHS's Heparin Advisor, but Crossings Healthcare Solutions is the subsidiary of UHS, and we market the tools that we use at our UHS hospitals. We were established in 2014 to provide clinical efficiencies, improve workflows, and enhancements to optimize Cerner Millennium. Our award-winning M pages and advisors have been installed at more than 85 hospitals across the US. And these solutions embed directly into your Cerner system. They increase usability, efficiency, and EHR experience. Again, we are a subsidiary of Universal Health Services, a 27 acute care hospital. We're headquartered in King of Prussia, Pennsylvania. And for the Crossings difference, we are fellow Cerner clients, so we understand the platform. Usability, efficiency, and satisfaction with Cerner platform matters to us just as much as it matters to everybody that is attending this webinar today. And we have dedicated resources such as clinicians, informaticists, analysts, and IT support. We have a little over 24 software modules available in our catalog. If you visit our website, you can see all of them. We have a planned release of one major software module per quarter, and we are following Cerner's best practices for M-Page development and implementation with the support of Cerner leadership. The Crossings pitch. Cerner's off-the-shelf products can be better. Organizations don't have the resources, time, or the expertise to complete this work. And Cerner's development cycles and priorities often don't fit all organizations. We utilize the development platform to enable efficiencies and solutions to common Cerner problems. We build flexible tools to accommodate localization and alignment with the Cerner model experience. And we make Cerner configuration intuitive, minimize clicks, navigation, and complexity. Without further ado, I'm going to pass it over to Giovanna, and we're going to start talking about our Heparin Advisor. Oh, sorry. This is our brag board. These are the clients that we work with currently at Crossings. Very proud of this, so we'll give it a second. Now we'll move to Giovanna to talk about the Heparin Advisor.
Thanks, Luke. All right, so everyone, we're just going to give you a little bit of background on the project, how the advisor came to be before we jump into the demo. So to give you guys a little bit of background, our facilities have reached out kind of numerous times expressing a desire for a better solution to manage inpatient therapeutic anticoagulations. As I'm sure you're all aware, heparin is a high-risk medication, and we were using a power plan workflow to manage it manually prior to implementing our advisor. Dr. Reddy will go into details and kind of show you how that works, but to kind of summarize that workflow, every time a lab result was resulted, our nurses would access a subphase of a power plan, review the protocol instructions, and then kind of manually make those adjustments. Heparin has some weight-based dosing, and this often meant the nurse would have to do some manual calculations and then finally arrive at that titration recommendation. So we got a lot of feedback that this was confusing for the nurses, and we could see that it could lead to some patient safety risks, such as errors in dose management. So we developed the Heparin Advisor with a goal in mind to create an electronic tool embedded in Cerner that will be used to manage these patients in a more effective, evidence-based manner. So we developed our Heparin Advisor, and it utilizes clinical decision support to present the nurse with the appropriate titration recommendations based on the patient's current condition. Essentially, the advisor analyzes our lab values, and then it presents the nurse with a recommendation that's appropriate and the next steps. So we've been able to take the manual calculations off the nurse and reduce human error by putting that all on the advisor. In addition to improving the workflow for our clinical staff, the advisor promotes quality and variation reduction across our acute care facilities. And since implementing, we have seen a decrease in the length of time it takes for our patients to meet that therapeutic range. And we've also seen a decrease in the number of critical values coming up as well. Next slide. So we developed 3 versions of the Heparin Advisor to assist in the continuous infusions. So we have a acute coronary syndrome, or essentially what is a low-dose version of a heparin protocol. We have a high-dose version that's for venous thromboembolisms or pulmonary embolisms. And then we also have a neurological syndrome or stroke version for our protocols. And this is essentially a low-dose version that has no initial or subsequent boluses in those recommendations. In addition to having protocols that can treat 3 different clinical conditions or multiple clinical conditions at this time, the advisor is also able to work with PTT or anti-10A lab monitoring based upon what the facility is using. And just a little bit of background of our project team and kind of how we implement it. So the big thing that we thought we had to do before we could start designing the advisor was come up with a standard protocol for each of our facilities. So basically, prior to the advisor, each of our facilities had their own version of a heparin protocol. And we felt that in order for our advisor to be effective, we needed to standardize that across our sites. So we got with our pharmacy teams, and they really were the driving force in getting a standard protocol developed, approved, and reviewed across all of our sites. We were able to develop a protocol that had some flexibility for our PTT values due to the nature of that lab. So basically, each facility was able to define their range values, but we provided a defined recommendation action for each associated value. Since anti-10A is more standard, we were able to create one protocol for all sites to use that have the same range values as well as the same recommended actions. Once we were able to kind of conquer that task, we began to design and build our protocol. Our advisor. Our project team consisted of Dr. Reddy, our physician, nurses, and pharmacists, and they were able to help us define our workflows and address any clinical concerns as they may come up. Once we had our kind of base version in place, we set out for a 2-pilot site pilot. They used the advisor for a couple months, gave us a lot of feedback, gave us some things that we could fine tune, and then we began a rollout across all of UHS. And at this point, the Heparin Advisor is the standard for heparin management and is used across all of our UHS sites. And I will hand it over to Dr. Reddy for the demo.
Thank you, Giovanna. Good afternoon, everyone. Thanks for joining the demo. Giovanna highlighted some of the issues we faced and some of the reasons why we went the advisor route for heparin. Just want to briefly go over the challenges I faced as a CMIO in trying to sort of get this message out and have a safe, effective tool available for all our hospitals. We went live in Cerner in 2013, and till 2018, we had a heparin power plant. And we tried to be very innovative with the power plan, working with the tools Cerner has. And we built a physician phase and a nursing phase within the power plan, which I will show you shortly. And all the titration instructions are not only included in the drip, we also have a nursing communication, which sort of helps the nurse to see what the titration recommendations are. There are a few things which we couldn't solve. One is many of you are aware that the heparin protocols have a max dose based on the weight. So how do we present within a power plan depending on the patient's weight, a weight-based dosing versus a max dosing. And the second challenge was trying to get the titrations as well and the units of measure we use for titration, because once a patient exceeds a certain weight, we go from milligram or ml per kilogram dosing, we go to a max dose, which is typically in units per hour. And we always had challenges at the pharmacy end trying to make sure that what is being recommended from a protocol perspective matches with what the drip titrations are, because that's the last thing we want is a disconnect between the nurse and the ordered recommendation, and make sure that both the units are aligned. And the third thing was trying to standardize the protocol across UHS. So taking all these things into consideration, we thought we should build an advisor. It was a venture for sure, but I think at the end, we came out with an amazing tool, which I want to show you. Can all of you hear me and see my screen okay?
We can hear you, Dr. Reddy. I don't know that you're sharing your screen yet.
Okay. I think there's a little bit of lag. Please bear with me.
Oh, here we go. It's working on your screen right now. Give it a second.
Yeah. Joanne, can you see if you're able to share your screen? I can't. Sorry.
I had an issue earlier. I just refreshed the page. If you can get back in, it may work that way. It's going to kick you out for a second, but then you'll come right back. I had an identical problem.
There you go.
Yeah, we got the page.
Just going to bring up the page. So I have a few test patients. Please bear with me. We have 2 test domains we are working through. And
Looks great. We're good to go. And if anyone's having trouble viewing, there is an option to make it full screen down at the bottom right. If you're viewing, blow it up. The four outward pointing arrows, you can full screen it, probably see it a little bit better.
Thanks, Luke. So this is an example of our high-dose VTE heparin infusion plan. And as I stated earlier, we have a weight-based cutoff. In this example, you have, if patient's weight is less than 125, 80 units per kilogram should be the default dose. And if the patient weight exceeds 125, for the initial bolus, we're supposed to present the 10,000 units heparin bolus. So for this, what we do is we use dynamic power plants where there are rules which you can build behind the power plant so that based on the patient's weight, in this example, patient is 60 kilograms, below 125 kilograms for the cutoff. So we automatically default 80 units per kilogram dosing. And then if in the instance where the patient weight is above 125, you would automatically only see 10,000 units bolus dose here. So we were able to achieve that with Cerner's dynamic flexing rule, which Cerner gives us. But the biggest challenge we had was what do we do with the subsequent titration? It's good for the provider to order the bolus and give a titration instruction to the nurse via nursing communication. But there are issues with that. One, timing of the 6-hour PTT. The nurse has to remember to order it because I can't order Q6 hours because the drip doesn't start the moment I order the protocol. So we have to find out a smart way to be able to default a 6-hour duration for the lab from the time the nurse starts the drip or from the time nurse does the subsequent titration. So that was one of the challenges. So here is an example of the nursing plan, which we have pre-selected in the Heparin protocol in the power plan. And what the nurse is expected to do is once there's a titration back, they're supposed to go in here to the power plan, open the power plan, click on the supplemental section of the plan, and then follow through these recommendations depending on what the range assay result is, and have to manually calculate the dosing and then follow through on the dosing. So this was a big challenge for us, and that's one of the reasons why we went through this, the advisor. The other challenge was in some of the recommendations, if you notice, it'll say rebolus either 40 units or 80 units and increase the drip rate by XYZ. And we have to give nurses bolus doses available within power chart to be able to order. We didn't want to order them and have them as a PRN because that's obviously a patient safety risk and we didn't want to crowd our bar. So what we did is we made them available in our supplemental plan. And if the nurse needed a 40 units bolus, they would have to make sure to remember and order the bolus and then also follow through on the titration recommendation. So that was our prior workflow before we went live with the advice. So I'm going to stop here and see if you had any questions with our prior workflow while I bring up the other patients, where we can demo the advice. So here is a domain where we have our advisor available. So what we did is we created a folder called advisors because at UHS we have heparin, we have TPN, and we have insulin, electrolyte, and sepsis. So we have multiple advisors we use where we leverage the technology to make sure that we are providing clinically relevant recommendations based on the patient's context. So in the advisor folder, we have a heparin VTE. I can also search advisor or heparin and do the same thing. Here, instead of seeing a power plan, I would see an advisor. So I can go ahead and order as a physician if I decide to place this patient on a heparin drip, this is what I would do. So if you notice here, the protocol is much leaner, and two, from a physician standpoint, there's no difference in the workflow. In scenario one, where we had only the power plan, the only difference was that the power plan was much longer because it had the supplemental plan and labs and every other thing that is needed to manage the protocol. Here, the plan is much leaner. So all the provider would do is come in here, order the bolus. We did not pre-select the bolus in the order set because at our institution, sometimes the ED already boluses the patient, and all they need to do is order the bolus and then go ahead and initiate the advisor. So from a physician standpoint, there's no change in the workflow prior to or after we went live with the advisor, which was one of the good things because it's hard to get physicians trained and on board, and there's a lot of confusion. And then once we order the advisor, one of the things we have in place is, this is an example of an anti-tenia protocol. Typically, we don't routinely order anti-tenia on patients unless we want the patient to be on Heparin protocol. So what the advisor does is it looks for an anti-tenia, and if there's no baseline anti-tenia ordered on the patient, it would prompt the provider to order the anti-tenia. And here I can go in and modify. And then also, we also need baseline coags. If they are missing, we also prompt the nurse to be able to do that, or the provider to be able to do that. And then once you're back in the plan, you could order the anti-tenia right here, and then go ahead and. So in this way, we make sure that we have the baseline coags available, and also to make sure that there's no elevated INR or other coagulopathy. And two, we also make sure that we have a baseline anti-tenia that is needed to titrate for the protocol is also ordered at the time the advisor order is placed. Any questions on the advisor provider workflow? Okay. So once the advisor is ordered, the labs are also placed through the advisor. If you notice, if I go into my order profile section, you will see the orders for the PTT anti-10A and INR. And once these labs are back and once the patient is on a heparin trip, when a new PTT or anti-10A level comes back, I have an example here of a patient. What we have, our table of contents is actionable, similar to some Cerner's functionality of Smart Zone. Smart Zone gives you alerting on the right side of the EMR. But the challenge with the Smart Zone is, at least based on when we evaluated it, was not actionable. It was only an FYI. So what we did is we came up with our own Smart Zone, which has broken down into three sections. One is the chart review here. It's similar to what you have on your TOC today at all our other Cerner client sites. The next section is called the to-do section. So anything which the nurse or the care team provider needs to take action on shows up on the to-do list. And once that action is, or the task is completed, those action items disappear. So this is a way of passively alerting a nurse that there is something which he or she needs to act on. And the third section is called the FYI. So this is more like a placeholder to say that this patient is either on certain protocols or certain important relevant information that we need to share with the team. A few examples would be patient has a Heparin Advisor order. This would be an example here. Other thing would be patient has fall precautions, patient has restraints. So anything which we feel are really important for the care team to be aware face up, we have those in the FYI section. And then the to-do section is where those action items show up dynamically based on either a lab result or any other satisfying concept we create. In this example, Heparin Advisor lab result coming back is an action item for the nurse. And here you would see that the action item shows up on the to-do list for the nurse. And it says there's a new heparin lab value available. And what the nurse needs to do now is click on it. And this would launch the advisor. And just navigating through the advisor, we have patient demographics on the top section here. There's always a question mark here, which when you click, you can reference the actual document of the protocol itself. So if a provider or a nurse has any concerns, this is a test domain. Let's see, try again. There you go. So any person following the protocol has access to the protocol right from within the advisor, and click on it at any time and to be able to reference it. On the right-hand section, we have relevant data that's necessary for management of heparin. We have labs, which include a CBC, coags, anti-10A, and under med section, we also have all antiplatelet agents and anticoagulants, which are currently active on the patient profile, because those pieces of information are relevant when managing heparin. So we have that information available handy face up within the advisor. And knowing the anti-10A protocol, we know that there are certain contraindications or certain clinical conditions where anti-10A monitoring might not be the right thing to do. And one of the big reasons is your baseline anti-10A is elevated. And if it is elevated, then you can no longer use anti-10A reliably to titrate heparin. So that's the reason why we haven't. nurse is following the protocol for the first time, we ask a question to the nurse, and the question is, and this question comes up only if your baseline anti-10A is elevated. So in this example, the anti-10A is 0.45, which is above the reference range. And since the anti-10A is elevated, we ask the nurse a question here. And the question is, was this anti-10A level drawn prior to administering heparin? We all know that if you're on oral anti-10A agents, at baseline, your anti-10A could be elevated. And in those instances, they should not be following anti-10A, it should be following the PTT monitoring. But it also could be a lab artifact where someone already gave a bolus and then the nurse accidentally drew the anti-10A level after heparin was given. And if that is the case, it's more of a lab artifact. And we wanted the option to have anti-10A monitoring still available in that instance. And then, so for the yes/no questions, we clearly give explanation for the nurse or provide guidance. It says, yes, this may indicate that the patient is on oral anti-10A at home, so using anti-10A monitoring is unreliable. No, patient received heparin prior to anti-10A. So we provide the guidance for the nurse to be able to answer this question appropriately. Say, for example, if this patient truly was on anti-10A at home and the level was elevated due to that reason, then I think the nurse would answer yes. And if the nurse does that, we automatically switch the patient to PTT monitoring, and the nurse will be presented with an option to order PTT 6 hours from that point onwards, so that the monitoring moving forward would be based on PTT and not anti-10A. Whereas if this is a lab artifact, the nurse would just select no, and then once they sign, the nurse would be presented with the recommendation if it is 6 hours from that point onwards. And since the nurse wanted to continue on anti-10A, the recommendation, so in this example, the anti-10A level was 0.45, and the current drip rate was 18. And then when you confirm it, then the advisor automatically calculates the dose, the titration recommendation based on the current heparin drip rate, and prompts or presents to the nurse what the changes that are needed to be made. In this example, it's saying draw an anti-10A 6 hours from the dose change, and the anti-10A level is therapeutic. You don't need to do anything. So that's why you're not being presented with any dose change recommendations or a bolus dose. I have another example where you could potentially have a bolus dose or an anti-10A dose present, and I will show that to you shortly. So now what the nurse would proceed to do is order the anti-10A, and since there's a CBC missing for morning, both those labs are pre-selected, and you should be able to order these as a nurse. And once I do that, you will notice that the action item goes away from the to-do list. I no longer have an action item for the heparin. And then if you go to your orders for the labs, you would see under lab section, you would see an order for anti-10A, and it says placed by the Heparin Advisor based on the protocol. And the same thing for the CBC, you will see this is placed by the Heparin Advisor, and this is defaulted for tomorrow morning. So the advisor presents those orders and places those orders as dictated by the protocol. For sites which are using PTT, the workflow is much straightforward. You don't need to answer that question of whether the PTT was elevated at baseline or not, since we know. And I have an example here of a PTT workflow where a result is back, and here is an example of PTT. So once a PTT lab result is back, so what the advisor is saying is current PTT 33 seconds, current heparin rate is 18. So one thing to remember here is the current heparin drip rate is being, the advisor looks at it from the eye view to see what the latest titration recommendation or the heparin drip rate is on the patient. And it also displays the date and time of the documentation of the heparin drip rate. And one of the things we always educate our nurses is, we know nurses are busy. Sometimes they go titrate the patient's pump and forget to go and confirm the volumes in the pump for sites that are using infusion management. And for sites that are not using infusion management, nurses might not have updated the iView to the most recent drip rate. So that's why we always want educate the nurses to say, before you hit confirm, make sure that the values you're seeing here, especially the current heparin drip rate, is accurate. If this information is stale, we always ask the nurse to exit out. We give a way out for the nurse so they can exit out of here, and then they can go to the iView and change the drip rate, and then come back again and relaunch the advisor to make sure that the drip rate that the advisor is seeing is always the most recent one and the most accurate one that the patient is receiving. And then once you confirm, so we could have automatically presented the titration, and that's the reason why we wanted the nurse to manually hit the confirm button, acknowledging that the numbers that he or she is seeing is accurate. And then once you hit confirm, here is an example where the PTT is subtherapeutic, and what the advisor is recommending is give a bolus dose of 80 units per kilogram, increase the drip rate by 2 units per kilogram to 20 units, and draw PTT 6 hours from now. Since the nurse needs to administer this 80, they no longer need to go into the power plan or go find an order and place the order. The advisor presents the order for them, calculates the dose, which is 4,800 units based on this patient's weight of 60 kilograms, and automatically pre-selects that order and presents it to the nurse. And then since the level is subtherapeutic, you need a PTT in 6 hours, so that order is pre-selected. If there's an AM draw, you would not be presented with an AM draw. It would not be pre-selected. And the advisor also has a logic based on the protocol that if you have 2 therapeutic levels, then you are no longer getting a 6-hour PTT. It's automatically asking you to get an AM PTT or an AM anticoagulation. So all that logic is built into the advisor. The other thing I wanted to focus on is the agreed proceed versus disagree here. So since this is a protocol-based recommendations, and we know from a patient standpoint, there's always workflow variations where maybe the patient is at high risk for bleeding, or patient just had a surgery and I resumed the drip, and you got instructions from the surgeon asking you to not titrate based on the recommendation, but go slow. The nurse always has a way to manage that and document it within the advisor, because from an advisor standpoint, when you're making recommendations, we want to document this information in the patient's chart, and this is a way of doing that. So what the nurse would do is would say disagree, physician directed, and then in this example, you would actually get an option to be able to document. In our latest upgrade, we have a pretext box, which
if you do that drop down for me, so you'll see there's 3 options. It defaults, as you saw, to the agree. Okay. And if you pick the other option, you have a free text. So we created the physician directed in case there wasn't a lot to elaborate on and you didn't have any additional information that you wanted to free text, but we also have a free text option too.
So there's always an option for the nurse to document within the advisor the reason why he or she have been deviating from the protocol. So once I do that, I want to document this to show you where this shows up. And then the nurse will go ahead and sign. You also notice we have here the entire history of the Heparin protocol. So what this does is it maps your PTT ranges that have been resulted throughout the protocol, as well as the doses that were administered in a graph manner. So if pharmacy is interested in looking at how this patient is doing throughout the duration of the protocol, we give you an easy way of accumulating all that data and presenting it in a flow sheet or in a graph format as needed. So let me go ahead and sign here. And now once I refresh the screen, sorry, I don't know what happened here.
You somehow jumped back to Mock West, Dr. Reddy. I don't know what
Yeah.
happened. I have, do you want me to just share my screen if the
I
domain?
can close this. Yeah, go ahead, if you don't mind.
Yeah,
Let
and
me stop
you
sharing.
can talk through. You want me to go to the flow sheet?
Yeah, if you can, if you don't mind.
Yeah, of course. Okay.
So what Giovanna is going to show is where all this information gets stored. We have a pharmacy anticoagulation flow sheet, which documents all the recommendations that were followed from the advisor. And it also has all the relevant antiplatelet agents, titration recommendations, everything in one place for you to be able to see when you are reviewing this chart or auditing this chart, or when if a provider wants to go see how this patient is doing from an advisor perspective. So every recommendation is sort of documented within the flow sheet. So that essentially concludes my demo. I know I have went through a lot of information here. I'm going to pause here, and I think we can take questions from the group, and then I can close it by showing some of the reportings we have to make sure that both from a process standpoint and an outcome standpoint, how did we manage this to make sure that, one, the advisor is being managed properly by our providers as well as nursing, and two, is the advisor really making a difference from a clinical standpoint? Ultimately, the patient care and outcomes are the reason why we do all this cool stuff. So we have some tools to actually measure that and help with successful Heparin Advisor implementation.
If you have any questions in the chat box, and then Dr. Reddy, I'll put up the final slides for you to speak to.
I presume everyone is not on mute.
It's going to be in the chat. They do not have the ability to, they don't have the ability to talk, but I'm monitoring the chat. It looks like there are no questions currently.
Okay.
Oh, so here we go. Here we go. One. Can you see that, Dr. Reddy?
Yes, I can. Yeah. So do you have process for pausing, suspending the heparin drip, and then restarting it? So the way we, so for pausing and restarting the drip, we look at it this way. We look at if the pause is going to be more than 6 hours, then it's essentially you're restarting a new protocol. So that's what we recommend. If we think that the patient is going to be off heparin for an extended period of time, if you want to start back the protocol, then you need to start fresh. But if it's temporary, you are holding for a procedure for an hour or two and restarting the drip, what you can always do is you can document zero in the heparin drip rate. So that's what we recommend. We want you to document that the patient has received 0 units per hour. And then once you get your new result for the PTT, because I'm sure you're repeating a PTT prior to starting the heparin or resuming the heparin, based on those values, the advisor has the logic built in to sort of tune back the patient on the protocol. I hope that answers the question. Any other questions? Yeah. So let me go over some of the analytics tools we have. As I mentioned, from a data analytics standpoint, we break it down always into process outcome. So the process measures are built into our business objects report. These are also available within Cerner to all our sites, and any nurse manager, quality personnel, pharmacy can run this in real time. And I'll show you what those reports look like in the next slide. And the next thing is outcomes. For outcomes, we use Healthy Analytics. And what we do is all the data flows into Healthy Analytics. And in Healthy Analytics, we have Tableau. And we are able to sort of pull that data into Tableau to visualize it better. And we have a dashboard which sort of goes through some of the measures from an outcome standpoint, which can be accessed and looked at in real time. Next slide, please. So this is an example of process improvement. So the two key metrics we look at is lab interval and recommendation. So for a protocol to be successful, we want to make sure, one, the patient is getting labs as recommended by the protocol. If you have a therapeutic level or a subtherapeutic level, and if you don't repeat a lab for 12 hours, then that's not good. So what we do is we monitor to see how frequently these patients are being monitored when the PTT is subtherapeutic. So that's what we call lab interval. So ideally, we would like this to be every 6 hours or at least close to 6 hours. And that we can monitor by running a report in real time. Anyone can have access to this and run and get that information. And the second one is the recommendation interval. Recommendation interval is where you have the labs getting resulted every 6 hours. And once the to-do action item shows up on the TOC, we want the nurse to act on it as quickly as possible. Because once the lab result is back, if the nurse doesn't get to it for 3 hours, 4 hours consistently, then we know that's a behavior change we need to address. And so what the recommendation interval does is how long did the nurse take once the result is back to act on that recommendation. And by meaning of acting on a recommendation, what we mean is you clicked open the advisor, you got your recommendation, and you signed the advisor. So we capture that signed date and time, and we measure the difference, and we sort of display that in a report for the recommendation. And as you see in the report, we have all the patient data, all the patients' information, demographic information, patient's location, when the recommendation came in, or when the trip rate was changed, and who the nurse was, or who the person managing the protocol was. So as a nurse manager, if I see a consistently a nurse not being compliant with this, either it could be an education issue or it could be someone whom we need to just have a conversation with. So I think this tool really gives provides that tool for the nurses or for the nursing supervisors or pharmacy or nurses to be able to manage the protocol in an effective way. Next slide, please. So the outcome measure. So what we thought had of what we should be measuring, and an ideal protocol, what we thought would be a good way to measure is we want the protocol to get therapeutic as quickly as we can. The goal is to get the patient therapeutic as quickly as we can. And I can achieve that by giving 1,000 units, which is, or I can achieve it by giving 10,000 units. But in the process, we don't want to cause patient harm. So we thought a good way of looking at it is what is the protocol's average time to therapeutic goal, and then how many critical anti-10A PTT results did we have? Because the ideal protocol should get the patient quickly therapeutic with the least amount of critical values or causing no patient harm, and that's what we do, and we measure those. We were a little overzealous with trying to measure percentage within goal. I think it became a little challenging because The goal for each hospital might be different because the reference ranges do not match. So we are still trying to see how we can do that. But those two are the big ones we focus on. And clearly we are seeing a significant improvement in the advisor world when compared to the power plant world in terms of these two measures. So that, and here is a timeline view within the dashboard where you can actually see, measure this over time and have a quick view. So this is the different views in the Heparin dashboard. We have a summary view, we have a timeline view, you have a detailed view where you can drill down to the patient itself to make sure that the data that is being presented in the dashboard is accurate. If someone wants to drill down into details, you can do right from the dashboard itself. So look, that concludes my demo. Any additional questions from the group or comments, feedback?
Excellent. And again, I want to thank both Giovanna and Dr. Reddy for taking the time out of their busy schedules to do this and present something that UHS is very proud of. And I'm sure these two are proud of it as well. We have a couple minutes left for questions. So if you have any, feel free to send in the text box. Also, obviously, if you want to inquire about the Heparin Advisor, send me an email. I will be following up with everybody who registered here. We'll be sending a recording of this out in case you want to forward it internally. And obviously, you can reach Giovanna or Dr. Reddy for questions in the future through me. It's also worth mentioning that at Crossings, we want to start doing more of these webinars. And the next one that we are planning on doing is our TPN Advisor. So keep an eye out for that. But we'll give it another minute or two to see if anybody has any questions. If not, I'll be following up with everybody. And thank you all for attending today. Awesome. Thank you guys. Thank you guys for attending. Awesome. Looks like we'll be able to give everybody 10 minutes back. We finished ahead of schedule. Good job, Dr. Reddy.
Thank you. Thank you, guys. Thanks for attending.
Awesome.
You can email me anytime. Luke will provide the email. If you have any clinical questions, feel free to reach out to Giovanna or myself directly if you need to.
I can connect you to either of them. So, yep, reach out to me and I can connect you to Dr. Reddy or Giovanna. Thank you, guys. We're going to close it out here. I'll be following up with everybody who attended. I appreciate it. And we'll see you later.